homeostasis. So this vitamin D, its synonyms. So on this topic, we'll study about the source of vitamin, chemistry of this vitamin D, function of vitamin D, deficiency manifestations of vitamin D. So synonyms, this vitamin D, it is called as a anti-rachitic vitamin. So this anti-rachitic vitamin means this on the deficiency of this vitamin, it causes this vitamin D deficiency. In children, it causes a rickets. So this rickets in children and osteomalacia in adults. So that is related with a deficiency of vitamin D. So deficiency of this vitamin D, it causes this rickets and uh, osteomalacia. So because of that, this vitamin D is also called as an anti-rachitic vitamin. And this vitamin D we can get. So the major source of vitamin D for human beings is to expose to the sunlight. So that's why this vitamin D, it is also called as a sunshine vitamin. Though you are not consuming a sufficient of vitamin D from a food, if you expose daily in the sunlight for more than 15 minutes, so that is quite enough to get vitamin D that is required for our body functions. So we should expose on the sunlight for minimum 15 minutes in the sunlight to get the required vitamin D necessary for our body. So it is also called as a sunshine vitamin. And the other synonym is that chemical name is the cholecalciferol. So calciferol. So chemistry. So when we look through the structure of this vitamin D, it is structurally it is derived from cyclopentanoperhydrophenanthrene. So you have seen this word that cyclopentanoperhydrophenanthrene on the. So this is the compound that is nucleus that is seen in all steroids, and it's so it is a nucleus presence on the all steroid compounds. So like this one, these steroid hormones like estrogen, progesterone, and the glucosaminocorticoids. So you can see this cyclopentanoperhydrophenanthrene, and those compound which contain a cyclopentanoperhydrophenanthrene, and for this the precursor is the cholesterol. So in human beings, this vitamin D, it can be synthesized from a cholesterol. So in nature we have a two active this vitamin D. So one is ergocalciferol, which is also called as vitamin D2, and next one is cholecalciferol, so which is also called as a vitamin D3. And the source of this ergocalciferol, this vitamin D2, it is generally we can get from a plant sources, and cholecalciferol, this vitamin D3. So it is we can get it from the animal source. And apart from the animal source, this vitamin D3, it can be synthesized in our body also by using a precursor 7-dehydrocholesterol. So in nature we have two provitamins. So natural provitamins, precursor for these vitamins. So one is ergosterol. So ergosterol, it is generally found in plants, and this is 7-dehydrocholesterol. So that is found in animal's skin. So which acts as a provitamin, and on these provitamins, they convert to the these vitamins, that is the ergocalciferol and cholecalciferol, when they are exposed with a UV light that is provided by a sunlight. So for the conversions of this ergosterol and 7-dehydrocholesterol to the ergocalciferol or cholecalciferol, so we need a specific wavelength, so ultraviolet light, so that have a specific wavelength in between 290 to 315 nanometer. A peak actions at this 297 nanometer, and after the exposing with this ultraviolet light, so it opens the B ring of this cyclopentant ring. So this four ring nucleus, it forms a cyclopentant perhydrophenantine ring. On that, this B ring, it's open when it treated with the ultraviolet light, so that it converted to the this vitamin. So ergosterol, it is converted to the vitamin D2, ergocalciferol, and this 7-dehydrocholesterol, it is converted to cholecalciferol. So that is the vitamin D3. So where this B ring of the steroid is open, and because of that, this ergocalciferol and cholecalciferol, they are also called as a secosteroids. So on which this B ring is closed, that is called as a steroids, and this vitamin D, so they are called as a secosteroids. So where this B ring is opened, so they are called as a secosteroids. And so we should remember the wavelength that is necessary to convert these provitamins to the vitamins. So that is in between 290 and 315. So that's why to get or access this vitamin D from a sunlight, we should expose on a sunlight in between in the morning after 8:15 to the before 3 p.m. of the day. So on that time, the ultraviolet light, it provides the this favorable wavelength, so which can able to convert this 7-dehydrocholesterol to the cholecalciferol, so which is the vitamin D. So the structures of these vitamin, so this D2 and D3. So you just the differentiations between the structures of this vitamin D2 and D3 is that is on the side chain, so which is attached on the carbon 17. So rest the structure is similar. So in both this D2 and D3, they contains a hydroxyl group on third carbon, and they both contain a double bond in between carbon number 5 and 6 and 7 and 8. And the hydrocarbon chain is present at carbon 17. So the differentiation between this ergocalciferol and cholecalciferol is that is the on the side chain only. And these both are equal active in our body. So dietary sources. So cholecalciferol we can get from an animal. So these fish liver oils such as cod, halibut. So this fleshy of oily fish, so like sardine, salmon, herring are the richest source for vitamin D. So that is the cholecalciferol. And this egg yolk, margarine, lard, these are the good source. And this butter and cheese, they contain some fair source. The milk, whereas this milk and mushroom are the poor source for vitamin D. So milk is a good source for calcium, but it is a poor source for vitamin D. So to get access to get a calcium from a milk, when we consume a milk, so we should supply the vitamin D. If the vitamin D is deficient, then you cannot get the calcium content in a milk. So some of you may be familiar with the advertisement given by this nutritional foods like this Vita, Horlicks. So which is that it is better to mix this Vita or Horlicks with a milk, because this Vita or milk, these Horlicks, they contain a vitamin D, and which is necessary for absorptions of calciums that is present in a milk. So plant. So ergosterol is widely distributed among plants, especially from ergot and the yeast. So however, the plants ergosterol, they are not absorbed well, hence they have a less nutritional importance in a human beings as a source of vitamin. So this, as mentioned earlier, so apart from this dietary source of vitamin D, this vitamin D can be synthesized in the skin of a human beings when they expose to the sunlight. So generally the sebaceous glands, so they are able to synthesize 7-dehydrocholesterol from a cholesterol, And by using this 7-dehydrocholesterol, these UV lights, it converts to the cholecalciferol. So it is the vitamin D3 in human beings. So even though if you are not consuming sufficient amounts of vitamin D from a dietary food, if you expose in the sunlight, so that is sufficient to get vitamin D in the body. So daily requirements. So adult and older children, so 200 international unit or 5 to 10 microgram per day. So pregnant and lactating mother, so it's a double of the normal. So that is 400 international unit or 10 microgram per day. So infant and children, so which are in a growing age, so for them also it is 400 international unit per day. And elder people, so for them also the necessity requirements of this vitamin D is 400 international unit per day. So elderly people, the more than 60, it is 600 international unit per day. So as the age gradually increases, so that means in the elderly people, so the rate of absorption of vitamin D3 is diminished. So that we should supply a more amounts of or more concentrations of vitamin D in elderly ages. So absorptions and transport, and generally, so we know that this vitamin D, so it is a fat soluble vitamin, and when this vitamin is present in a food, generally it is associated, this vitamin D is bind with a fatty acid to form a vitamin D store. So when it reaches on a small intestine, this specific enzyme, so the storage enzyme, so it hydrolyzes this vitamin D into free vitamin D and free fatty acids. So along with the this hydrolyzed, partially hydrolyzed fats, this vitamin D is absorbed from duodenum and jejunum. For that, it requires a bile salt. And I hope that all of you are familiar with why bile salt is necessary for the absorption of vitamin D. So this for the absorption of these fats, it should be formed as a mixed micelles, and this for the formations of mixed micelles, this bile salt is necessary. So this vitamin D, after absorbed from intestinal lumen, that is for duodenum and the jejunum, on the epithelial cell of intestine, this vitamin D again it esterified with this one. Now this vitamin D along with the other fats, it is complex with a chylomicron, and and in the form of this chylomicron droplet, it is enters to the circulate via the lime. And in circulations, there is a specific binding proteins are present, which is called as vitamin D binding protein, so DBP. So and this vitamin D now it combined with a vitamin D binding protein in the circulations for transport. So the vitamin D, that is the cholecalciferol that we earlier mentions, that this vitamin D is also synthesized in a skin. So when this 7-dehydrocholesterol is treated with UV light, so this cholecalciferol is formed, that is the vitamin D. So thus from vitamin D, it also enter to the circulations and bind with the vitamin D binding protein. So they are transported to the target tissues in the same form, that is the complex with a vitamin D binding protein. And generally this vitamin D, it is stored in a liver and adipose tissue. So that on the circulations, so it is D binding proteins. So they are binding with this vitamin D. They are binding with this vitamin D binding proteins, and they are transported to the liver and adipose tissue where it is stored. So this cholecalciferol, it is not an active form of vitamin D, and this cholecalciferol should be converted to the active form, which is called as calcitriol. And the conversions of this cholecalciferol to the active vitamin D, that is a calcitriol, it takes place in a liver and kidney. So vitamin D is considered a pro-hormone. So without biological activity, to acquire its functional properties, it must undergo chemical change. So this cholecalciferol and ergocalciferol also follow the same chemical transformations. So that form a calcitriol, and which is takes place in a liver and kidney. So on liver, so there is the enzymes called as cholecalciferol 25 hydroxylase. So that is present in a liver, and this cholecalciferol 25 hydroxylase enzyme, it inserts a hydroxyl group on the 25th carbon of cholecalciferol to form a 25 hydroxy cholecalciferol. So this takes place in a liver. So where insertions of one hydroxyl groups under 25th carbon to form a 25 hydroxy cholecalciferol. So we can say it is a calcidiol also, so which contains a 2 hydroxy group, 25 hydroxy cholecalciferol or calcidiol. So the formations of this 25 hydroxy cholecalciferol is proportional to the vitamin D3 supplied. If the excess amount of this vitamin D3 is supplied, then more amounts of this 25 hydroxy D3 is formed. So that the conversions of this cholecalciferol to the 25 hydroxy calciferol is proportional. It is directly related with the how much of vitamin D3 is supplied. So after formations of this cholecalciferol 25, so 25 hydroxycholecalciferol, after formations of this 25 hydroxycholecalciferol, now this 25 hydroxycholecalciferol again it enters to the circulations from a liver, and on circulations it again bind with the this protein called as a vitamin D binding protein. So that is the DBP. So DBP binds both this cholecalciferol, and so this vitamin D binding protein, it can able to bind with a 25 hydroxy cholecalciferol. So this 25 hydroxy cholecalciferol after formations in a liver, in a circulation it bind with a vitamin D binding protein. It complex with the vitamin D binding protein, and in this form it enters to the intestine. So this 25 hydroxy cholecalciferol bound to the specific vitamin D binding protein and is carried to the kidney. So during this, and in the form this so it enters to the renal tubules via the this glomerular filtrations, this one glomerulus, and in renal tubules, so in the proximal tubules, this 25 hydroxy cholecalciferol, so it is reabsorbed and is transported into the mitochondria of the tubular cell, and where these another enzymes called as a simple name, that is the 1 alpha hydroxylase. So that is the full name is, that is the 25 hydroxy cholecalciferol 1 alpha hydroxylase. So which add another hydroxyl group on the first carbon. So which add a hydroxyl group on the first carbon to form a 1,25 dihydroxy cholecalciferol or calcitriol. So this is the formations of active vitamin D. So this calcitriol is a active vitamin D, and the conversions of this pro vitamin, so that is the cholecalciferol to the calcitriol. It is takes place in a liver and kidney. So first one that takes place in a liver, so that is the insertions of hydroxy group on the 25th carbon of cholecalciferol to form a 25 hydroxy cholecalciferol. And the second one, it takes place in the second insertions of hydroxy group on the first carbon, which is takes place in the mitochondria of tubular cells in the kidney, and it forms a 125 dihydroxy cholecalciferol, and which is also called as a calcitriol. And this 1 alpha hydroxylase enzyme, so that is the rate limiting enzyme for the formations of this calcitriol. So it is regulated by these concentrations of these calciums and phosphate, also by these feedback mechanisms. So now next one, that formation of 24-25 hydroxycholecalciferol. So these tubular mitochondrial tubular cells, apart from 1 alpha hydroxylase, these cells, they also contains another enzymes called as 24 hydroxylase. And this 24 hydroxylase, it inserts hydroxyl groups under 24th carbon of this 25 hydroxycholecalciferol to form this 24-25 dihydroxycholecalciferol. And this 24-25 dihydroxycholecalciferol is less active than this 1,25 dihydroxycholecalciferol or calcitriol. So it is a less active calcitriol hormone. And these are the formations of this 24-25 dihydroxycholecalciferol. That is also takes place on the mitochondria of renal tubules. And this 1 alpha hydroxylase and 24 hydroxylase are highly regulated factors. So that triggers the productions of 1,25 dihydroxycholecalciferol and inhibits the formation of 24-25 dihydroxycholecalciferol and vice versa. So that is the meaning that this 1 alpha hydroxylase, it enhances the synthesis of 1,25 dihydroxycholecalciferol, and this 1,25 dihydroxycholecalciferol, it inhibits the this formations of this one. So it inhibits the formations of 24-25 dihydroxycholecalciferol, and this 24 hydroxylase, it stimulates the formations of 24-25 dihydroxycholecalciferol, but inhibits the formation of 1,25 dihydroxycholecalciferol. However, if there is a excess concentrations of calcitriol, so that means if in renal tubules that the excess amounts of 1,25 dihydroxycholecalciferol is formed, then this excess amount of this calcitriol, it induces the synthesis of 24 hydroxylase, so which helps to convert this 25 dihydroxy so 25 hydroxycholecalciferol to the 24-25 dihydroxycholecalciferol. So in normal condition, in physiological concentrations, it inhibits the synthesis of 24-25 dihydroxycholecalciferol. But in increased concentrations, calcitriol, it induces the synthesis of 24 hydroxylase, so by which it enhances the synthesis of 24-25 dihydroxycholecalciferol. So that's how the concentrations of calcitriol is maintained. So apart from these regulations, this alpha hydroxylase is also regulated by the these minerals also. That means this calcium and phosphate. So they regulate alpha hydroxylase by means of feedback inhibition. So when there is a high concentrations of calcium and phosphate, it inhibits the activity of alpha hydroxylase, and when there is the low concentrations of calcium and phosphate in the circulations, it enhances the activity of alpha hydroxylase. And apart from that, this alpha hydroxylase activity is also stimulated by the parathyroid hormone and the other hormones like estrogens and growth hormones. So functional role of this vitamin D. So the main functions of the vitamin D is it regulates the calcium and phosphate homeostasis. And generally the main function of this vitamin D is it increases the extracellular levels of calcium and phosphorus. That means it increases the concentrations of calcium and phosphorus in the circulations. So this vitamin D, it mainly targets to increasing the concentrations of this calcium and phosphorus in a serum or plasma. It mainly acts on the three main organs. So that is the intestinal mucosa, bone, and kidney. So the actions, mechanism of actions of this vitamin D, this vitamin D, that is the calcitriol, it can show its actions by genomic as well as the non-genomic actions. And the other precursors of this vitamin D, that is the 24-25 dihydroxycholecalciferol and 25 hydroxycholecalciferol. So they are less active than the calcitriol. So genomic actions. So genomic action is similar to the other steroid hormones. So in the nucleus of the cell, there is a specific receptors for vitamin D is present. So there is a vitamin D receptors are present in the nucleus. So and these like other these steroid hormones or thyroid hormones or this vitamin A. So this vitamin D, they can easily transport across the cell. They can transport across the cell membrane and to the from the nucleus membrane also. So they can easily transport. They can easily enter to the nucleus. And on nucleus, this calcitriol, it binds with these specific receptors called as a DDR. So that is the vitamin D receptors. And after bind with this, after forming the complex with the receptors, now it forms a heterodimers with the retinoid receptors. So generally these retinoid receptors, so it is usually present on the promoter sites of DNA. So after forming of these heterodimers, now it is able to bind with a vitamin D responsive elements on the DNA. So generally this vitamin D responsive element, so that is present on the promoter sequence of a DNA. And after binding of this vitamin D on the DNA, they are now able to modulate the transcriptional activity of vitamin D responsive genes. So generally this vitamin D, it stimulates the transcriptions of this calcium binding protein called as a cal binding. It stimulates the transcriptions of the alkaline phosphatase gene, it is calcium ATPase gene. So 25 hydroxy cholecalciferol, it is 24 hydroxylase enzyme. And apart from that, it also stimulates the synthesis of the transcriptions of gene, which is responsible for a synthesis of various proteins in a bone matrix, like this collagen 1, osteocalcin, bone siloprotein, and osteoportin. So which is necessary for the mineralizations of a bone. So non-genomic actions. So this vitamin D is also able to show its actions. We had a non-genomic actions. For that, generally this vitamin D, so they bind to the membrane receptors present on the cell membrane called as a vitamin D receptors. And after binding of these receptors, it causes the these activations of different these carrier proteins. So like these calcium channel activations, so enhanced phospholipid metabolisms, so increased membrane fluidity and elevated intracellular calcium concentrations and the prostaglandin productions. So effect on intestine. So the main functions of vitamin D on the intestine, it increases the absorptions of this dietary calcium and phosphate. So for this, it shows its actions via the both this one non-genomic as well as the genomic actions. So non-genomic, generally it bind with this vitamin D, it's bind with the these calcium channels present on the cell membrane, and which increases the absorptions of calcium to the cell from my intestinal lumen. And it also stimulates the synthesis of calbindin protein and the calcium ATPase protein, so which is necessary for the absorptions of calcium. And apart from that, this vitamin D also increases the phosphate absorptions in the distal jejunum and the ileum. So in overall effects of vitamin D on intestine, it increases the calcium and phosphate absorptions. So for that, first it increases the synthesis of these calvanding proteins and calcium ATPase, and after that it bind with the calcium channels so that uh, which enhances the absorptions of calcium from a lumen to the intestinal cell. So we are discussing on the function of vitamin D. So the main function of vitamin D is it involved in a calcium homeostasis, and on calcium homeostasis also the main function of this vitamin D is that is the it increases the concentrations of this calcium and phosphates in a circulation. So that means it increases, and for that it acts on the three main target organs, that is intestine, bone, and kidney. On intestine, it promotes the absorptions of calcium and phosphorus from a dietary sources, and on bone it promotes the mineralizations and the remodeling of a bone. So it increases this calcium and phosphate uptake from a circulations to the bone, and apart from that, for the mineralization, it increases the synthesis of these different proteins necessary for this one bone mineralizations, like this one type 1 collagen, bone siloprotein, osteopontin, and osteocalcium. And apart from that, it also promotes the formation of bone matrix. So effects on kidney. So on kidney, this vitamin D, it activates the reabsorptions of calcium and phosphate from renal tubules. So which prevents the excretions of calcium and phosphate, and so that it retains the concentrations of calcium and phosphate in a circulation. So on parathyroid gland, this vitamin D, it suppresses the this parathyroid hormone synthesis and secretion, and modulates the parathyroid response to the serum calcium level. So other actions of this vitamin D is that it regulates the expressions of over 100 genes, so which function exceed those related to the calcium homeostasis. So it also have this one extra calcium actions, so that means which is not related with the calcium homeostasis. So the functions of vitamin D, which is not related to the calcium homeostasis, are it has been found to have a modulatory effects on a immune hematopoietic system. So it reduces the risk of cancer and coronary heart disease. And this vitamin D is beneficial. It has a beneficial effects in the patients with AIDS. And there's another another this form of this vitamin D, that means 24 25 so dihydroxy cholecalciferol is essential for this bone fracture repair, acting by paracrine, autocrine, or endocrine mechanisms. So this comparing to calcitriol, this 24-25 dihydroxy cholecalciferol, it is a less active, and so its function is not well established. However, it is found beneficial, necessary for bone fracture repair, systemic endocrine mechanisms. So fate of calcitriol. So the half-life of this calcitriol is around 6 to 8 hours. So oxidations of side chain causes the inactivation, and after the inactivated form, it is excreted through the bile. So under normal conditions, in kidney, hydroxylations add 24 positions where 24 hydroxylase to 24 calcitriol occurs. So this 24 calcitriols, that is it's a compound which is less active than calcitriol. So the more active form of this vitamin D, that is the calcitriol, and this 24 calcitriol, so it is a less active, so that it do not possess the activity like this calcitriol. So deficiency. So the normal concentrations, normal level of this vitamin D in the circulations is it should be more than 30 nanogram per ml. However, the toxic level is more than 150 nanogram per ml. So when the concentration is in between 20 to 30 nanogram per ml, it is called as a vitamin D insufficiency. And if the persons have less than 20 nanogram per ml of vitamin D, then it is called as a deficiency. So prevalence of deficiency. So generally this deficiency of vitamin D is more common in infants. So generally it's 78% deficient during winter. So in this vitamin D deficiency is more common in a winter than a summer. So it's because, so already we have seen that this vitamin D formations in a skin by the this ultraviolet light. So for that it requires a specific wavelength that is in between 290 to 315 nanometer, and peak this wavelength is 297 nanometer. And during a winter, this wavelength of a sunlight, that ultraviolet light, it is not fall in between this 290 and 315, so which is necessary for a vitamin D synthesis. So so because of that in winter, so even we exposed to the sunlight also, this vitamin D formations is diminished. And another is another cause of this vitamin D deficiency in winter is that is we generally we cover our body with a heavy clothes, so that this sunlight, that means UV light, they cannot penetrate to the skin. So in children, growing children, the deficiency is common. It is 9% of the children, they generally have a deficient. 61% of the children, they may have a insufficient this vitamin D. So hospitalized patients, so those who are lying on a bed for a long period, so they also shows the deficiency of this vitamin D. So generally when we lying for a more time in a room, that means it reduces the exposure of the people with the sunlight, so which causes the reduced synthesis of the vitamin D. And generally this vitamin D is also it can be decreased in case it can be seen deficient among the Afro-Americans. So generally 40 to 52% are deficient. So these so those persons who have a dark pigmentation, that means the this who contains a more amounts of this melanin, and this melanin, it inhibits the, it protects the persons from a UV light, so that it prevents the formations of vitamin D in the skin. So these those persons who have a more amounts of melanin, they are generally deficient on the vitamin D. So causes for vitamin D deficiency. So one is that is a decreased sun exposure, or even if you are exposed with the sun using of this sunscreen. So if you are using more than this SPF 15, then it decreases the vitamin D synthesis by 99%. And the air pollutions, it also interferes the this wavelength of sunlight, ultraviolet light, so which prevents the synthesis of vitamin. And next cause of this deficiency is that the decreased intake of food which is rich in vitamin D. And the persons who have a malabsorptions such as steatorrhea, so they even you even we consume a more amounts of vitamin D in a food, but it cannot be absorbed well, and which lead to the vitamin D deficient. And in chronic kidney diseases, so on kidney diseases, so we know that the conversions of this vitamin D into the active form vitamin D, that is the calcitriol, that takes place in the liver and kidney. So those persons who have a disease, liver diseases and kidney disease, so on that what happen, this vitamin D, the sufficient amount of calcitriol cannot be synthesized, and which lead to the vitamin D deficient. So additional risk factor for this vitamin D deficient are the premature birth, skin pigmentations, so obesity, advanced age, immigrants. So that means the persons immigrate to the places where the where they are far from 45-degree latitude from a this equator. So there is the deficiency of the wavelength necessary for the conversions of 7-dehydro cholesterol to the cholecalciferol. So which makes them the vitamin D deficient. In case of obesity, what happened is vitamin D, it is stored in a adipose tissues, and then it is not released. So they are trapped under the adipose tissue and not released to the circulation. So which make them a vitamin D deficient. So risk factors for vitamin D deficiency. So generally the risk factor that is in age older than 65 years. After the under elderly age people, so there is the diminished absorptions of vitamin D from a intestine. Exclusively breastfeed without a vitamin D supplementations. Dark skin, so which contains a more melanin, so that prevents the conversions of this vitamin 7-dehydroxy cholesterol to the cholecalciferol. So insufficient sunlight exposure, so obesity, sedentary life, and use of medications such as these are anticonvulsant and steroid drugs, so which also lowers the vitamin D, that lead to the vitamin D deficiency. So deficiency manifestations. So as earlier mentioned, so this deficiency manifestations of vitamin D is that in children it shows a rickets, and in adults it's a osteomalacia. So type of rickets. So classical rickets where there is the absolutely deficiency of vitamin D, so which shows the rickets. So that called as a classical rickets. And another one is hypophosphatic rickets. In hypophosphatemic rickets, so there is the reduced reabsorptions of phosphate from a renal tubule, so which develop a rickets. So on this case, along with a vitamin D, if we supply a phosphate also, then it's a beneficial. So next one is that is the vitamin D resistant rickets, and generally it is these vitamin D resistant rickets are seen in case of the Fanconi syndromes, where the reabsorptions of bicarbonates, these amino acids, and these phosphates are altered. And next one is that is a renal rickets. So on renal rickets, due to the so due in which the conversions of this cholecalciferol to the calcitriol is affected. So that is a calcitriol, that vitamin D active form of vitamin D formation is altered, so which is called as a renal rickets. So next one is that is the in organ refractoriness. Though the persons contain a sufficient amounts of vitamin D, due to the lack of the receptors on the organs, so which lead to the vitamin D deficient syndrome symptoms. So which is called as a end organ refractoriness. So in this case, what happened? The number of the receptors, vitamin D receptors on the target organs are reduced. So ricket, so that meaning on old English, that is the to twist. So clinical features, insufficient mineralizations of the bone. So that's why what happened, the bones are weak, and when the persons keep the load on that bone, then these bones get bent. So that forms a deformities of the bone. So affected organs are teeth, skull, chest, spine, legs, and the pelvis. So clinical manifestations of these rickets are these craniotypes, bow legs, knock knee, ricket rosary, so bulging of frontal bones, and the pigeon chest. So you can see the picture of this rickets person. So these bones they get bent. So curved humerus, so curved femur, so curved tibia. So uh, due to the load on the weak bone, so this bone start bend. So because of that, what happened? The persons have difficulty to walk. So this is the picture of this rickets, so where the bone get bent. So osteomalacia, so generally it is seen in the these adults. So in Greek, this osteon means that bone and malakia means that softness. So due to the this one, due to the low, due to the deficiency of vitamin D, the sufficient amounts of calcium and phosphate, they cannot get minerals on the bone, so that the bone become a weak. So they are softened. So generally it is seen in a pregnancy and the women in a purda. So where they wear a this black cloth, so which prevents the exposure of the skin to the sunlight, so that there is a decreased vitamin D. And generally in osteomalacia, the bone aches and the pain are common, and it is easy to fracture, so prone to fracture. And this osteomalacia also seen in case of the persons who is using a phenobarbital for a long period. So osteoporosis, so generally it is seen in the elderly people, and generally it is due to the decreased photolysis of provitamin. So on the elderly people, what happened? The conversions of cholesterol to the 7-dehydrocholesterol is diminished, and due to the lack of the 7-dehydrocholesterol, this vitamin D, that is a cholecalciferol formations in the skin is decreased, and there is also decrease in the sex hormone productions. So that lead to the formations of vitamin D is diminished and lead to the osteoporosis. So biochemical symptom of vitamin D deficiency is, that is the hypocalcemia and hypophosphatemia. So the concentrations of calcium and phosphate is decrease in the circulation. So preventions, this vitamin D deficiency can be prevented by exposing to the sunlight, and this external supplementations of vitamin D during a winter, where the synthesis formations of vitamin D is less. So supplement, so this vitamin D should be supplied into the this additional person, like in where this vitamin D is necessary for a more. So like in conditions like this pregnant mother, breastfed infants, children, growing children, elderly people, and the other high risk people. So this supplementation generally recommended as on the adult 800 to 1000 international units, a maximum of 2000 international unit daily. So treatment of deficiency, so on high doses ergocalciferol 50,000 international unit weekly once for 8 weeks. And this high dose given of ergocalciferol is, that is, it is D2 is not as well absorbed as it is cholecalciferol. So maintenance, this cholecalciferol supplementation 800 to 200 international unit daily, higher in certain. And sunlight, so that is 15 to 45 minutes non-burning midday sun, so depending on skin pigment, so several times per week. So hypervitaminosis, so immediate effects, if the persons consume more amounts of vitamin D, then it lead to the hypervitaminosis. The immediate effects of hypervitaminosis is, that is the anorexia, thirst, lassitude, constipations, and polyuria. So later followed by nausea, vomiting, and diarrhea. So delayed effects of this hypervitaminosis is, that is the hypercalcemia and hyperphosphatemia, lead to urinary lithiasis and metastatic calcifications of kidney, bronchi, pulmonary alveoli, muscles, artery, and gastric mucosa. So delayed effects, that is the long-term effects of this hypervitaminosis, that is the formations of these stones, so calcium and phosphate stones over the different tissues, like this kidney, so bronchi, pulmonary alveoli, muscles, artery, and gastric mucosa. So thank you for your kind attention.